Welcome to Nursing 542, Module 6, Endocrine Metabolic Assessment and Diagnosis. Just when you began to think that no system could be more complex than the cardiovascular system, along comes the module on endocrine and metabolic systems. This week we'll be focusing on the assessment and diagnosis of endocrine metabolic conditions in the primary care setting. While certainly not an exhaustive list of the potential endocrine metabolic disorders you'll see in primary care, these are the conditions that we'll focus on in this module and next week when we move to management of disorders related to the endocrine and metabolic systems. A more thorough discussion of anemias will be covered in next semester's hematology section, so we'll just briefly cover it here. First up, here's some red flag conditions that you'll want to be able to recognize. As an AGNP, you probably won't diagnose too many diabetes type 1 cases, but I thought I'd include it as imperative to catch. So be aware of these red flag conditions that you want to recognize these symptoms of. In previous modules, it's been relatively easy to list the most common complaints for a system, for example, dyspnea for pulmonary, chest pain for cardiac, but with endocrine metabolic disorders, the complaints are typically more general and vague, particularly in older patients. Sometimes endocrine or metabolic disorders are only identified via routine screening. Many of the symptoms or disorders can be brought on by medication, so a thorough medication review is always a good idea. First topic is pancreatitis. Although alcoholism is frequently the first thought that comes to mind when we hear pancreatitis, it is the second most common cause of acute pancreatitis, with gallstones being the leading cause of acute pancreatitis. Hypertriglyceridemia, try and say that fast 3 times, can also cause acute pancreatitis. A small percentage of acute pancreatitis occurs after undergoing an endoscopic retrograde cholangiopancreatography. Boy, that's even harder. I like to call that the ERCP. Alcohol is associated with chronic pancreatitis, however, not necessarily only in alcoholics, but also in patients who have drank small amounts of alcohol on a regular basis over a long period of time. Cigarette smoking is known to contribute to chronic pancreatitis independently and is also known to increase the severity of disease in idiopathic and alcohol-caused chronic pancreatitis. So here you'll see on this slide differences or the symptoms and such with acute versus chronic pancreatitis. Acute pancreatitis. The abdominal pain present with acute pancreatitis can vary from mild to severe, but it is more commonly severe, located in the epigastric region, described as a boring pain, and radiates to the back. The pain is typically worse in the supine position, with some relief obtained from sitting up with the trunk flexed and the knees drawn up. Colons and gray turners are uncommon and indicates severe disease. Up to 20% of patients with acute pancreatitis will have pulmonary abnormalities such as basilar rales, atelectasis, and pleural effusion. 2 of the 3 are required to diagnose acute pancreatitis. Clinical presentation of typical abdominal pain, serum pancreatic enzymes at or beyond 3 times the normal level, and abnormal imaging consistent with diagnosis. So you need 2 out of 3 of those. The ERCP is rarely utilized for diagnostics now and has commonly been replaced by the MRCP. So the ERCP is typically used now for stent placement. Leukocytosis, hypocalcemia, and hyperglycemia may be present with acute pancreatitis. Hematocrit greater than 44%, a BUN greater than 22, and signs of organ failure are indicators of severe disease. With chronic pancreatitis, patients have abdominal pain varying from mild to quite severe. Some, approximately 20%, present without a history of abdominal pain. Pain can be intermittent or constant and may be exacerbated by eating. Textbook symptom with chronic pancreatitis is the oily, malodorous stools. The elevated pancreatic enzymes typical with acute pancreatitis are not commonly present with chronic pancreatitis. The elevated bilirubin and alkaline phosphatase are related to bile duct stricture. And again, the MRCP is the imaging study of choice. Pancreatic cancer presentation is epigastric pain, jaundice, and late disease, weight loss, and atypical diabetes, stool and urine changes, lighter stool and darker urine, and the diagnostics are labs and abdominal imaging. Pancreatic cancer cannot be diagnosed based on clinical presentation. Oftentimes, a diagnosis of diabetes precedes a diagnosis of pancreatic cancer. In an elderly patient newly diagnosed with diabetes, or any patient without risk factors and development of diabetes, you should consider the possibility of pancreatic cancer. For patients highly suspicious for pancreatic cancer, a CT with contrast is a diagnostic of choice. Serum liver enzymes and bilirubin should be drawn on all patients presenting with jaundice or epigastric pain to assess cholestasis. Liver function labs will be elevated. Tumor markers CA19-9 and CEA are also typically elevated with pancreatic cancer. Moving on to diabetes, which is a very common condition that you will undoubtedly see a lot of regardless of your practice setting. The prevalence in the United States is estimated between 6 and 13%, and huge numbers of people are estimated to have diabetes that have not been diagnosed. The prevalence in the U.S. doubled between 1990 and 2008, and with our increasingly higher rate of obesity, even among children, the prevalence is anticipated to continue to rise. Diabetes has traditionally been classified into type 1 and type 2. However, the classifications have blurred a bit over the years, as children are more commonly being diagnosed, unfortunately, with type 2, and type 2 patients are requiring insulin therapy, and also because type 2 patients are known to experience diabetic ketoacidosis. Although DKA in a type 2 patient is rare, it generally occurs with severe infection or illness. It does occur, though. And diabetes type 2 accounts for 90% of the diabetes. We'll mostly be focusing on that in this lecture. This slide outlines the textbook symptoms, presentation in diabetes, polyuria, frequent urination, frequent thirst, nighttime urination, although many are asymptomatic as well. In type 1, the first presentation may be their DKA. So the majority of diabetes type 2 is diagnosed on screening, as many patients are asymptomatic or just don't recognize the symptoms until after they're diagnosed. Rarely, diabetes type 2 will present with weight loss or blurred vision as their chief complaint. With type 1, the patient, as I said, may present in DKA. Although most type 1 diagnoses are made in childhood, approximately 25% are diagnosed after age 35, so you need to be aware of this. Marked unexplained weight loss, a short history of severe symptoms, and moderate to heavy ketonuria suggest type 1 diabetes. Because most patients are asymptomatic, screening is essential. Screening for diabetes should be done in asymptomatic individuals at any age with greater than one of the risk factors listed here. All adults 45 years and up should be screened, especially those who are overweight. If results are normal, repeat screening should be performed in 3 years or annually in patients with 2 or more risk factors. Sooner, of course, if the patient develops symptoms suggestive of diabetes. Screening can be done via A1C, a fasting plasma glucose, or 2-hour plasma glucose after 75 grams of oral glucose tolerance test. The diagnostic criteria are listed here. Pre-diabetes, A1C of 5.7 to 6.4%. Diabetes, the diagnosis if the A1C is 6.5 or greater, or fasting plasma glucose is equal to or greater than 126, or 2-hour post-glucose tolerance test of greater than 200, or if you have classic symptoms of hyperglycemia and a random plasma glucose of greater than 200. And again, just like blood pressure, you don't want to diagnose on one reading, so this should be repeated on a subsequent day, the same test that you initially find the diagnosis on. And A1C is the most convenient but also the most expensive means of diagnosing, so you need to consider that when determining which diagnostic to run. And again, the A1C of 5.7 to 6.4 is considered pre-diabetes, and patients in this range should be aggressively monitored, educated on lifestyle changes, and strongly encouraged to make necessary changes to avoid progression to the disease. Thyroid disease is another disease that is quite common and another condition which you'll undoubtedly be faced with in primary care. Overwhelming majority of hypothyroid cases are primary hypothyroidism, and the majority of hyperthyroid cases are Graves' disease. Hashimoto's disease is the most common cause of primary hypothyroidism and occurs most commonly in middle to older aged females. These are the symptoms that occur most commonly in patients with hypothyroidism, but note that many report no symptoms. And again, these are quite vague. And these are the symptoms that are even less commonly reported, but should still raise your suspicions for hypothyroidism. These are the symptoms that are experienced by less than 50% of the patients with hypothyroidism. As far as diagnostics, thyroid stimulating hormone, TSH, is the gold standard. You can also get a free T4. If the TSH is elevated, it's primary hypothyroidism. If the TSH, free T4, and T3 are all low, suspected pituitary or brain etiology. Recommendations for when to screen vary depending upon which group's recommendations you follow. Family practice physicians, thyroid association, endocrinologists, and college of physicians all have their own recommendations that vary a bit. And I'm going here with the American Thyroid Association because the prevalence rate is cited as 1 in 8 women over age 35, so it seemed logical to me that 35 was a good time to start screening asymptomatic patients. And pregnancy has their own specific recommendations for screening, to screen at the beginning of pregnancy, at the end of the first trimester, and ideally at the end of the second trimester. Down syndrome and type 1 diabetics are higher rate of hypothyroidism, so Down syndrome patients should be screened annually, and diabetic patients regularly. Hyperthyroidism, Graves' disease is the most common form of this, and it's more common among the elderly than the general population, so if you are working with elderly people, you want to keep that in mind. These are the most common symptoms in patients with hyperthyroidism. These are the ones that are experienced by greater than 50% of the patients with hyperthyroidism. As usual, the elderly may present atypically, and their complaints may be lethargy or new onset angina. These are less common symptoms of hyperthyroidism, yet again indicative of possible hyperthyroidism. These are experienced by less than 50% of people. Graves' disease, you'll see a suppressed TSH with normal or elevated free T4, a high normal 24-hour radioactive iodine uptake, and this is a factory problem. Thyroiditis is a suppressed TSH with normal or elevated free T4, a low 24-hour radioactive iodine uptake, and it may resolve on its own or convert to hypothyroidism. And Hashimoto's is the most common thyroiditis, and it's a warehouse problem. Thyroid storm, I should have put this under a red flag heading because it is a potentially life-threatening condition in which you need to be very aware, but it's typically precipitated by medical crisis or extreme stress. But these are the symptoms there: extreme irritability, delirium, coma, fever, tachycardia, hypotension, and vomiting. Moving on to osteoporosis. Osteoporosis is low bone mineral density and microarchitectural deterioration of bone tissue that results in increased fragility of bone and higher risk of fractures. Most commonly occurs among postmenopausal women, but it does occur in premenopausal women and men. Approximately 10 million people in the U.S. suffer from osteoporosis, and 80% of those with osteoporosis are women, 20% men. Generally, as I mentioned, osteoporosis is a disease of older women with naturally occurring estrogen deficiency secondary to menopause, but premenopausal osteoporosis occurs for these most common causes. low body weight, eating disorder, excessive exercise, hyperprolactinemia, or hypopituitarism. Premature ovarian failure, as occurs with Turner syndrome, and also chemotherapy, like breast cancer patients. The chemotherapy often causes premature ovarian failure, and they would be at greater risk for osteoporosis. These are the risk factors for osteoporosis, and they apply to both men and women, although women are at greater risk. Medications that contribute to osteoporosis include glucocorticoids, anticonvulsants, antidepressants, and high doses of synthetic progesterone, medroxyprogesterone, and that's used as treatment for abnormal menses. Again, the risk factors for osteoporosis: cigarette smoking, alcoholism, any GI disease that impacts absorption, hyperthyroidism, hyperparathyroidism, and hypercalciuria, physical inactivity, say bed rest people are definitely at greater risk for osteoporosis. Asian and Caucasian females have a higher incidence of osteoporosis, low body weight, light-haired, light-skinned females, and the medications that I listed previously. As far as screening, women greater than 65 years of age should be screened for osteoporosis, or women less than 65-year-old, postmenopausal with one or more risk factor, premenopausal women with a history of fragility fracture and risk factors. And men, there seems to be no consensus. Some say screen men with clinical manifestations such as radiographic osteopenia, or fragility fracture, or loss of height of 1.5 inches or more. Others say screen all men over 70 years old and those between 50 and 70 with risk factors. And a fragility factor, or fracture, is one that occurs from standing height, like a ground level fall, or lower without major trauma, like it's not a motor vehicle accident or anything. If you fall, you ought not to break a bone unless your bones are fragile. So, and also key to this when you look at the risk factors is that you need to measure the height on all your patients at least yearly so that you'll be aware of any loss in height, a loss of height. Oftentimes I think that's overlooked in our normal preventative measures. The diagnosis of osteoporosis in postmenopausal women, bone mineral density on DEXA scan of 2.5 standard deviations below young adult mean. That's called a T-score, less than or equal to negative 2.5, and that's with or without a fragility fracture. Premenopausal women, their score is a Z-score because that compares their score to age-matched normals. And so theirs needs to be a Z-score of less than negative 2.0 and risk factors in order to be diagnosed with osteoporosis. Men greater than 50, it's the same as the postmenopausal women. They have a T-score that needs to be at or below negative 2.5, and they use a male database to calculate that. And men less than 50, it's a Z-score, again, age-matched normals, and they need to be at negative 2 standard deviations below their age-matched normals and have a fragility fracture or risk factors. Anemia is covered, like I mentioned, in more detail in the hematologic section of next semester's course. I'll give you something to look forward to. And typically anemia is diagnosed on routine lab work. Or the anemias we're going to discuss, like chronic disease, is normocytic, iron deficiency anemia is microcytic, and vitamin deficiency anemia is a folate deficiency, which is B9, or B12, which is pernicious anemia, is a subtype of that, or vitamin C deficiency anemia you can have too. These are macrocytic anemias. As I mentioned, most anemias are identified on normal lab work, or routine. It's not normal. In anemia of chronic disease, the serum ferritin levels are normal to high, but the problem is an inability to utilize these iron stores. This anemia is more common among the elderly and can coexist with iron deficiency anemia. The anemias have differences in their underlying cause. Although rare, iron deficiency anemia can be due to insufficient diet. Rarely is that the case among adults in the United States, but it is more common among low socioeconomic patients and especially children who don't get enough iron intake. Anemia of chronic disease is often overlooked or masked by the symptoms of the chronic disease. Very vague symptoms, generalized fatigue and weakness, pallor, and if severe, they may have more obvious symptoms such as dyspnea, tachycardia, or palpitations. Moving on to general nutrition topics, malnutrition. I think when people hear the term malnutrition, they think of a very thin person, but it can also be obesity falls under the category of malnutrition because it's an issue of poor nutrition and it can manifest as being abnormally thin or obese. Calculation of BMI is a straightforward way of determining if a patient is too thin or too heavy. However, determining a patient's nutritional status and identifying potential issues before they become extreme takes more than simply calculating the BMI. As a primary care provider, you should include nutritional assessment as part of your preventive care routinely with all patients, regardless of their BMI. Regular documentation, as I mentioned earlier, of height and weight is essential at every visit, as changes may alert you to further investigate many potential disease processes, but changes won't be identified until they're extreme unless the height and weight is regularly recorded. Medication reviews should also be done on a regular basis, as many medications can contribute to changes in weight and or appetite. Eating disorders here, anorexia nervosa, bulimia nervosa. Clinical presentation of anorexia includes low body weight, distorted self-image, and abnormal fear of weight gain. Other characteristics that may be present include an obsession with food and exercise, poor self-esteem, control issues, perfectionism, eating rituals, extreme activity levels, overestimation of caloric intake, depression, inability to express emotions, suicidality, and other neuropsychiatric abnormalities may accompany eating disorders, so you need to be aware of that. As indicated on the slide, it is more common among females, but it does occur in males, so don't overlook that in your male patients as well. And the bulimia patients will have a closer to normal BMI, although they'll still generally be thin. Be aware that many patients will go to great lengths to disguise their illness, place heavy objects in their clothing during weight documentation, etc. Once the patient is horrifically thin, then the diagnosis may be obvious, but it would be good to identify it earlier. Family members may indicate concerns while the patient continues to deny any difficulties, and psychiatric referral may very well be required. There are multiple screening tools. One is the SCOFF, the COFF screening, and you'll see the questions that make up that screening tool here. And you may want to utilize the screening tool at the earliest indication of any eating concerns. I've placed many of the ADA standards of medical care in the module for your use this week. I hope those are helpful. I know there's a lot of information covered here, and we'll next week talk about management of these same illnesses.